A 72-year-old with heart failure is admitted after increasing shortness of breath. Lab value is sodium is 130 mmol per liter, which finding and nursing action are appropriate. Select all that apply. Thank you guys. Thank you for double tapping. Really appreciate. Confusion. We know we are having a patient with heart failure. So what happened in heart failure, guys? What happened? Accumulation of fluid. Everyone happy with that? And we are having sodium 130. So in heart failure, we have too much fluid accumulation. Okay, so this is not direct electrolyte imbalance. This is delusional hyponatremia, too much fluid over there. Okay, if we will treat the heart failure, sodium is automatically gonna get better. Okay, confusion and decreased level of consciousness, is it correct? So same thing, same rationale we done in hyponatremia before, because we are having hyponatremia here. We are having, there will be too much, fluid loss into the blood brain, and then it will cause the cerebral edema, and then it will affect the neurological function. So we will see confusion, we will see decreased level of consciousness. What about assess for peripheral edema and daily weight? Is B correct? B is correct. Yes. Okay. B is definitely correct, because this is the essential part. This is the good part, because when we have less sodium, fluid is gonna go out. If we will have hypernatremia, we will see dehydration. If we have hyponatremia, we will see edema. What about fluid restriction and oral care for dry mouth? What about C? C, yes. Yes, because the even though it is hyponatremia, the reason behind this is heart failure, too much accumulation of fluid. Okay, so if you are giving too much fluid, it is gonna worsen it. So that's why we need to restrict the fluid, and we need to provide the oral care for dry mouth. Okay, we can use the because we need to do the oral care, especially if there is a fluid restriction going on. What about D, guys? Encourage high salt diet immediately. So this is again the classical word. Don't do anything. Never correct sodium immediately. Okay. And again, the problem is, yes, the problem is not sodium, the problem is water. Okay, salt restriction, if you are giving too much salt, it's gonna accumulate too much water, and that's gonna put effect on heart and respiration. Okay, so we don't wanna increase that. Our goal should be to reduce the fluid. Sometimes they will have diuretic. Okay, monitor for seizures. Is E correct? Is E correct? Yes, definitely, because we know hyponatremia, we are losing too much fluid inside the blood cavity, brain also, increasing intracerebral pressure, losing the consciousness, having the confusion. Okay, so seizure will happen definitely over there. Let's move to question number 12. A patient on high dose IV furosemide have potassium 2.9. Okay, so we know furosemide is loop diuretic, and that does excrete potassium, sodium, and water. Which manifestation and nursing priority apply? Select all that apply. So what is the normal level of potassium? 3.5 to 5. Everyone happy with that? And now we are having hypokalemia from furosemide. Okay, so do we need to monitor rhythms in hypokalemia? Yes, Okay, because hypokalemia can cause life-threatening arrhythmias, such as you will see U wave, you will see flattened T waves, you will see ventricular arrhythmia. Patient can go into PVC, VFib. Okay, prepare IV potassium bolus, push for rapid correction. So this is again nothing fast, nothing. This is push. We never do push. Okay, so B is no. What about C? Monitor for muscle cramp and weakness. Yes. So now we don't have enough neuromuscular function going on. So definitely you're gonna see more muscle cramps and more weakness. Okay, so C is correct. Check dioxin level if on dioxin and hold dose if low potassium. What will happen with hypokalemia and dioxin? We just done that question about dioxin. What will happen with hypokalemia? Cardiac arrest. Yes, thank you, bestie. Because patient have higher chances of dioxin toxicity. Okay, so we always need to check dioxin level and hold the dose if potassium is low, just to prevent the toxicity. What about E, guys? Encourage oral potassium rich food. Is it correct? Is it safe? It is oral. Okay, yes. Okay, so this is no direct push or anything. Body is gonna absorb on certain level amount. It's not going straight into the IV. So this is correct. This is the best way. Okay, let's move to question number 13. So post thyroidectomy, can you explain D? Okay, so dioxin we just have done in the last question also. Please do watch this video later on at YouTube. Dioxin hypokalemia, because if there is a hyperkalemia, there is too much potassium in body, because dioxin work on sodium potassium pump on the cardiac membranes, and that's how it reduce or increase or decrease the cardiac contractibility. So if there is too much potassium, that will bind to the sodium potassium pump, and then dioxin will bind less. But if there is a hypokalemia, there is not too much potassium available to bind to that pump, sodium potassium pump. So there are higher chances of dioxin to bind to that pump. Okay, that's why it will cause the increase the drug toxicity. You are seeing too much effect on the body. It's not desired effect, it's more than desired. Righty. Okay, let's do question number 13. Post thyroidectomy patient calcium is 1.9 mmol per liter. What is normal level of calcium, guys? Please do there. And which sign and nursing interventions are expected? So is it hypercalcemia or is it hypocalcemia? 9 to 11. Is it dangerously low then? Yes, hypocalcemia. And we know, because like parathyroid gland does manage the level of calcium in our body. So post thyroidectomy, you're gonna see hypocalcium. Okay. Okay, what can happen? And we done this one. Positive chvastic sign, trouser signs. Definitely A. Yeah, this is the classical sign of hypocalcemia. Okay, it is hallmark sign. This one is related to the, you will have when we are doing the blood pressure, increasing the blood pressure in cuff, and it will cause the spasm, and this will be around the facial nerve. Okay, facial spasm when we will tap on the facial nerve. Okay, what about B? Place on seizure precaution. We done that. B is yes. Okay, we done that. Hypomagnesemia, hypocalcemia, hypernatremia, they all cause seizure. Okay, two are hypo, one is hyper. So place on seizure precaution, because what is gonna happen when there is less calcium in the body, you're gonna see hyper reflex. Okay, too much neuromuscular excitability, and that will put patient into the spasm, and that will put patient into the seizure. That's why you have spasm in these both signs. Okay, thank you everyone for following and double tapping, really appreciate. Prepare IV calcium gluconate for symptomatic hypocalcemia. What about C, guys? Yes, okay, so we can give calcium gluconate. If we are having symptomatic hypocalcemia, definitely we can give calcium chloride, calcium gluconate, depend upon the how other electrolytes are doing. Okay, seizure precaution, the three cause are hypocalcemia, hypomagnesemia, and hypernatremia. Okay, two are hypo, magnesium and calcium, and one is hyper, sodium. Okay, they are three cause of seizure, and that's the reason you don't correct sodium too fast also, because that will cause the demyelination of the nerves. Okay, encourage high phosphate diet. Encourage high phosphate diet. What will happen if, and we discussed that, do we gonna encourage it or not? D is yes, no. D is no, guys. D is no, because we just discussed that phosphate always bind with calcium. Okay, phosphate bind with calcium, so we already having severe hypocalcemia. So if you're gonna give too much phosphate to the patient, then you're gonna make it worse. Okay, so we need to make sure we don't give too much phosphate to patient. Okay, monitor for prolonged QT on ECG. Can hypocalcemia cause prolonged QT? Yes. Okay, definitely E, because it is gonna increase the QT interval. It will, what kind of ECG we will see, what we don't wanna see in patient with hypocalcemia. Life-threatening arrhythmia. Which kind of arrhythmia can happen in hypocalcemia? AFib, TDP, torsades de pointus. We don't want to go into that one. Okay, patient can go easily into cardiac arrest. Let's go question number 14. So a chronic alcoholic in withdrawal. Okay, so now this is the another thing. I'm gonna post video. I already made video on how to solve the case study. It will be posted on nursing. So there are three components in every case study. One is patient, one is intervention, and one is disease. Okay, these three component always you guys need to note. So here is chronic alcoholic. Okay, and acute situation is going on, withdrawal. Okay, that's how we need to break. Magnesium is less, 0.4 mg. Is it less or high? What is happening here? Hypomagnesemia, yeah, we already discussion, because like what happened when we have chronic alcohol, that does impair the kidney function, and then there will be less magnesium reabsorption, and it will increase the renal excretion of that one. So 0.4 is critically low. Okay, and we know magnesium is very effective in muscle and nerve function. It does have sedative effect like on the normal level and higher level. But what's gonna happen, because now there is less magnesium, you're gonna definitely see excitability in patient, heightened neuromuscular functions, everything. Okay, yeah. So hyperreflexia tremor, definitely we will see that, because magnesium deficit cause increased neuromuscular excitability. Okay, it will cause hyperreflexia, it will cause tremor, it will cause muscle twitching, everything. Okay, increase deep tendon muscles twitching, everything. Torsades de pointus risk, continuous cardiac monitoring is B correct? Yes. Okay, B is yes, because we know we just magnesium maintain cardiac rhythm. Okay, magnesium maintain cardiac rhythm, so that's why we need to, if it is critically low 0.4, then definitely we need to put patient on the cardiac monitoring. What about C, guys? Administer IV magnesium sulfate per order. So this is the golden rule. It is per order. Is it gonna be correct? C, yes. Okay. So we have some golden rule for NCLEX. Most of the time, as prescribed per order is correct. Okay. D, assess for respiratory depression only if symptomatic. Is D correct? When you gonna see D, no, what we gonna see? We are seeing neuromuscular excitability. Okay, yeah, and you are now gonna see into hypomagnesemia. We are not gonna see that into hypo. We will see that into hyper. When we give too much magnesium to patient, that have sedative effect, and that's why we need to watch. Okay. Provide oral magnesium oxide as first line rapid therapy. Is that gonna help? So now we having 0.4. It is critically low. Do you think oral is gonna help? No. Okay, so that's not gonna help at all. It is used for the mild cases only, and it's not rapid acting. Okay, it's not rapid therapy, and it's not the first line rapid therapy. Okay, yes. Okay, let's move to question number 15. A patient with tumor lysis syndrome, we just have done that. After chemotherapy, which electrolyte are related complications should nurse monitor? These questions are repeated, guys, in NCLEX, honestly. So that's why these questions are coming up, and this is the best way to remember these what we say electrolytes. Okay, so make sure you guys keep learning. Okay, hyperkalemia. We know we just done tumor lysis syndrome in last question to destruction of the cancerous cell. So what is leaking into the body? We potassium, phosphate, and uric acid. Okay, because that are intracellular component. Potassium and phosphate in intracellular, and uric acid is present in the nuclei of the cell. So that's why you will have destruction, and those component will be released into the blood cell. Hyperkalemia with peak T waves is correct. Yes, Vinny, because cell lysis will um, excrete, or what we will say, release the potassium from the intracellular space into the blood, so that will cause the hyperkalemia, and peak T wave is the key sign of hyperkalemia, so that's correct. Hyperphosphatemia leading to secondary hypocalcemia, B is correct. We done B. Yes. Okay. The same rationale we done before. Hyperphosphatemia. Now we know we getting too much phosphate from the intracellular compartment. But hypocalcemia, because calcium is present in the blood cell and phosphate always bind with the calcium. So that's why you will see the hypocalcemia. Uric acid increase causing renal injury. Is C correct? What about C, guys? Yes. Okay, because uric acid we are getting from the nucleic acid into the cell, lyse cell, and it kidney can't actually excrete it because it get crystallized. Okay, so that's why C is correct. It will cause the renal injury. Hypomagnesemia as primary finding. What is the primary finding of tumor lysis syndrome? Anyone? No. Yeah, this is incorrect. Okay, what is the primary finding of tumor lysis syndrome? Anyone? Primary finding are A and B. Okay, tumor lysis syndrome, too much destruction of the cancerous cell, especially after the chemotherapy. Primary finding is hyperkalemia hyperphosphatemia. Okay, because cells are now releasing calcium, potassium and phosphate into the body, extracellular fluid. Monitor urine output and aggressive IV hydration. E, do we need to monitor that? Yes. Okay, so this is the thing, we want to do aggressive IV hydration because we want more urine output so body can flush it as soon as fast and possible. Okay, so that's why in TLS definitely we do the aggressive IV hydration and we need to monitor the urine output. Why we need to monitor urine output? Because like if you are still doing the aggressive IV hydration and patient is not excreting enough urine, if patient is going through the oliguria, that is saying that this uric acid is has caused renal injury. Okay, so we need to watch for that one. That's why we need to, yes, make sure no kidney damage. Thank you. Okay, let's do question number 16. A person with bulimia nervosa has frequent vomiting. What kind can anybody define that quickly in their present with metabolic alkalosis? Okay, so we are having alkalosis over there. Which assessment intervention are appropriate? Select all that apply. So what happened in bulimia nervosa? Frequent vomiting, too much, loss of stomach acid. So we are not keeping stomach acid. Yes, they do. Um, so what happened with that, the loss of acid due to the vomiting will increase the bicarbonate level into the body. Okay, and this will cause metabolic alkalosis. Okay, too much vomiting can cause that. And if somebody is having too much diarrhea, that will cause the metabolic acidosis, because then we are excreting the bicarbonate ion. Okay, so in this one we are vomiting, patient is vomiting, so that's why we will see metabolic alkalosis. Hypokalemia and muscle weakness expected. What about A, guys? What about A? Yes, is A correct? Yes. So vomiting also, because we are losing potassium. Okay, so that's why it will happen. Administer antiemetic and start potassium replacement as order. So this is anyway gonna be correct. I never seen any question incorrect when it come to as ordered. Okay, yeah, so this is definitely gonna be, so we need to stop the antiemetics. We need to administer antiemetic to stop the vomiting, and then we need to start the potassium replacement because we don't want patient to go into hypokalemia and arrhythmias. What about C? Evaluate for respiratory compensation, hypoventilation. What's gonna happen? Because patient is having metabolic alkalosis, the body is trying to compensate. Yeah, is C correct? Yeah, actually, C is correct, guys, because this is evaluation. This is also, we are not doing anything, we are just monitoring. Okay, we are just monitoring here because body compensate for metabolic alkalosis by slowing the breathing. Yeah, so which will increase the carbonic acid and lower the blood pH. Yeah. Okay, so if we will have too much acidosis, then you will have too much respiration, hypoventilation, hyperventilation, because body will try to blow off the acid. Yes, compensate. Okay, so that's why we will evaluate this one. What about D, guys? Encourage sodium bicarbonate tablets to correct alkalosis. Can you do that? D, no, it's base. Yes. Okay, sodium carbonate is base. You are having alkalosis. We are gonna go on the wrong side of the road. Okay, so we don't wanna do this. It will worsen the condition. What about E, guys? Monitor for arrhythmias and orthostatic hypotension. We just done that. Yes, E is yes, because we just done that. Because hypokalemia can cause arrhythmias and orthostatic hypotension. Because why? Hypovolemia. The body is not retaining the fluid. Body is having vomiting. Patient is dehydrated. We are having hypovolemia kind of shock. And in hypovolemia, you will always see orthostatic hypotension. Okay. Alrighty, let's do question number 17. A patient is receiving TPN suddenly develop hyperglycemia and low phosphorus. Which statement applies? So we know TPN is nutritional support, yeah, total parenteral nutrition. Um, Suddenly develop hyperglycemia and low phosphorus. Why? What's going on here? What's going on here with this patient? What kind of syndrome we see in TPN? Even now I said syndrome, so it is syndrome. There are not many syndrome with TPN, if you guys remember any. Refeeding, yes, triple. Okay, we are having refeeding syndrome here, and refeeding syndrome is always potentially fatal because there is too much potential fatal shift in electrolytes and fluid. Okay, mostly it happen in the patient who are on TPN because they are malnourished and suddenly they start getting the TPN. It will cause too much shift into the electrolytes in the fluid and sudden influx of glucose, because you know glucose we need potassium. Yes, so we need phosphorus, we need magnesium. Okay, that will change, everything change. Refeeding syndrome risk with hypophosphatemia. Is A correct? A, yes, yes. Okay, A is correct because too much hyperglycemia now, and then you need phosphate for that, and now body is working on the sodium potassium pump. Okay, and phosphorus also we gonna need, but this one is phosphorus is hallmark sign of the condition. Okay, so you're gonna see that one. What about the monitor for muscle weakness and respiratory insufficiency? Why we are having this one? Again, phosphorus. Okay, again we are having this for phosphorus. Alrighty, B is correct. What about C, guys? Check magnesium and potassium as they may also low shift. Is it correct? C, yes. Okay, C always yes. Because intracellularly, especially initiation of the feeding, these does change. And we always know when we have hyperglycemia for the insulin release, we need potassium. Okay. What about D? Stop TPN permanently to prevent further problem. Is it correct or incorrect? What about D? D is no. Okay, we don't want to stop it permanently. We don't want to stop it permanently. Okay, yeah. Give IV phosphate replacement per order. Can you give IV phosphate? Yes. Okay, because again, sometimes this doesn't indicate IV push. This is just indicating IV per order. So that's why it is correct. Okay, that's why we are seeing this as correct option. Let's move to question number 18. ABG is okay. Now we have ABG interpretation. So ABG is 7.28, pH is 7.28, carbon dioxide partial pressure is 55, and we have sodium bicarbonate 24. which are true. First of all, we need to find out what's going on. Let's do that. Okay, let's find out. So is but when we are doing the ABG interpretation, always check the pH first. Is it acidosis or is it alkalosis? 7.25 to 7.35 is normal. Yes. Okay, 7.25 to 7.35 is normal. Is it? But this is more toward the acid. So that's why it's acidosis. Okay. PaC2 is 55. So now we need to check. Next, we need to check the carbon dioxide. What is the normal ABG values? What is the normal carbon dioxide? 35 to 45. Yes. Oh yeah, 7.35 to 7.45. Thank you. Thank you. Yeah. Thank you guys. 7.35 to 7.45, that's normal. 35 to 45 is more calcium. Carbon dioxide. So this is 45. So this is more toward this side. Okay, 55. Yeah. I was confused also, Jocelyn. Okay, so we know according to Rome, respiratory is gonna be opposite and metabolic is gonna be equal. So we are having 7.28. Okay, and that is this side. And now we are seeing opposite. We are seeing opposite effect here. Okay, because pH is on this side and the carbon dioxide on this side. So this is respiratory. Alrighty. So this is primary acidosis, respiratory acidosis. Yes. So this is confirmed by this one. What about B? Hypoventilation or acute COPD exacerbation likely cause. What about B? Is it correct? Yes, okay. Because in COPD and hypoventilation, now we are retaining the acid, retaining the carbon dioxide. Okay, so that's why we can see respiratory acidosis over there. Okay, now patient expect increase PaCO2 retention. That's what we just discussed. And possible hypercapnic encephalopathy. Is C correct? Yes, okay, because now we are retaining too much of carbon dioxide in our body and that will have narcotic effect on the brain. Okay, when we say hypercapnic encephalopathy, you will see confusion, you will see lethargy, you will see coma, everything over there. Okay, hyperopia, high CO2. Yes. What about D, guys? Compensatory metabolic alkalosis is expected immediately. So this is the keyword here. Is it gonna happen immediately? Can body compensate immediately? No. Okay, body can't compensate immediately. Body needs some time. Kidney takes hours to days. Okay, if it is metabolic, kidney takes hours to days to compensate by retaining the bicarbonate. Okay, so it's not gonna happen immediately. What about E? Provide bronchodilator and improve ventilation as priority. Is it correct? Is yes, because we just discussed in option B that this can be the reason, likely the cause, hypoventilation and acute COPD. So if in that one we will improve the ventilation and we will provide the bronchodilator, it will treat the cause. Okay, and then patient will not retain too much carbon dioxide and then patient will be good. Okay, thank you guys for correcting me, really appreciate. Question number 19. Again, This time I'm not gonna forget the values. Okay, so we have pH 7.51, that is alkalosis, so 7.35 to 7.45. So we have 7.51 on this side, and we have PaCO2 28. Okay, that is 35 to 45 normal, and we have 28, so that is more on this side. Okay, so this is pH, this is CO2, and we have HCO3, so that is 22 to 26 is always normal, and we have 22 to 26, and we are here. Okay, what we are having? Respiratory alkalosis. Yes, respiratory alkalosis, guy. It is compensating. Yes, it is compensatory because bicarbonate is on the other side. Yeah, all good. Nice. Alkalosis. So it is HCO is in the normal, so that's why it's not the metabolic. Okay, and it's Rome opposite to each other, respiratory opposites, so that's why we have that one. Okay, primary respiratory alkalosis. Everyone happy with A? Everyone happy with A? Yes. Okay, it's respiratory alkalosis. The high pH and low PaCO2 does confirm that. What about B? Likely cause is anxiety, hyperventilation, early salicylate poisoning. Florical, definitely I will explain. Just give me few minutes. I will definitely explain. Okay, just after 20 question. Yes, B is correct. B is correct because common cause of hyperventilation is that when patient is anxious, when patient we have pain, when we have salicylate like aspirin poisoning, we do hyperventilate and we are not retaining enough CO2. We are blowing off CO2 and that will cause the alkalosis. Okay. What about C? What about C, guys? Hypokalemia and paresthesis. No or yes? C, yes. C is yes, guys. Okay, there is mixed answer coming from the comments, but C is yes. Alrighty. We can see because now what we having alkalosis and it can cause the intracellular shift, especially the potassium. Okay, and it can also decrease the calcium in body. Okay, and when we have everything is up beside K, yes, it can do the ionized calcium, it can decrease the ionized calcium also, and that can cause paresthesia. So C is correct. D, encourage breathe retaining paper bag breathing for rebreathing CO2. So we know hyperventilation, we know just to D, just to D. Yeah, I will explain that one, Jocelyn. What about E? What about E? Is no? Yes. E is no, guys. Okay. Yeah. We don't want to give immediately. Sorry, I'm just okay. Why we have um why we have paresthesia? Anyone? Hypocalcemia? Yes. Low potassium and low calcium. Okay. That's what happen in the we have cellular shift in alkalosis, and that's why. Okay. That's why we will have paresthesia and we need to monitor the potassium over there. Okay. Let's do last question and then we will study bit how to do the ABG interpretation. Okay. And that we will just do now after 20 question. And then we will see if we want to move to next 10 question. A patient with DKA arrive with potassium 5.5 mmol per liter and glucose is 28 mmol per liter. Which are correct nursing action and consideration? Let's do 20s. Last question for right now. So we are having DKA, we are having 5.5. It is high, it is bit high just to A. Yes. Okay, because insulin does help with potassium, sodium potassium pump on the, pancreas. So that's why it will help to reduce. What about B? Place and cardiac monitor for hyperkalemia sign. Definitely, cardiac monitoring is required for hypokalemia hyperkalemia. Okay, because it can cause arrhythmia and dysarrhythmias. Give IV potassium immediately, regardless of ECG. Can you give IV potassium immediately? No. Okay, we don't want to do that. What about D? Check for dehydration and initiate IV fluid. Isn't IV fluid the common treatment in DKA? Yes. Okay, this one is the best way. Okay, so we need to give, because DKA can cause severe dehydration. So we need to do the IV fluid. It is, I know it is DKA, but it is putting patient into symptom like HHS. Expect metabolic acidosis and compensatory hyperventilation. Yes, yes. It's DKA. It is gonna be metabolic acidosis, hyperventilation. Patient is now blowing off carbon dioxide just to compensate it. Just to E. Thank you guys. So we have done 20 questions for today. We will quickly do the ABG interpretation and then we will see how we are going. I will take 5-minute break